if I could ask you to, one, wait till you've got a microphone in your hand, but two, try and keep it to 2 or 3 key points from the discussion. Start with this table here.
Hi there. We've actually got 7 points, and I'll be really quick. Okay.
It's not a good start.
I know. Leading on, I think it was from my idea, the dual registration. Only joking. We thought, what about a national NHS card? Now, there are comments about affordability and data protection and security, that kind of thing, but you have an NHS card that you can go and see anyone, anywhere, swipe it, that brings up your name, you put in the password and it brings up your medical records, and that was it. Leading on from that, as patients, all we want to do when we're feeling unwell or we're concerned is go and see a GP, good quality service. We don't care who pays him or how he gets paid, we just want to see a GP. Why change doctors? And this is just from our table. Not very good service, access not there when needed, no customer service, rude staff and doctors, moving from one house to another, moving area, why do we need to change if it's close, and continuity of care for long-term conditions was a major point now. PCT needs, if this is going to happen and move forward, obviously the PCT needs to watch trends and be ready for the increasing demand, possibly in inner cities. This one was a work in progress, and we got booed a bit, but should a cap be put on GP services to protect residents? So, 50% all residents come first. Whatever happens, it's got to be proven to be efficient, cost effective before any change is made. And should GPs be allowed to refuse anyone?
We've basically covered a whole range of views. One of them was that employees in the population need to take more responsibility and ownership for their health as an individual. We need national standards across the board, not just between PCTs, we need to be national standards. PCTs rather than GPs need to get involvement in understanding their population. For example, if GPs need to start marketing to get patients, which they've never done before, that maybe needs to be on a PCT level. And also our single-handed practices can suffer purely because we're talking about the upper cap in the city. Well, if you've got a commuter belt with single-handed practice, then they can also suffer, and there'll be a lower cap potential in place as well as an upper cap as well. So those are some of the issues that we have.
In London, there were already a number of ways that one could get access services. There's extended hours in about 50% of the practices. There are walk-in centres in most boroughs. There are now going to be GP-led health centres in every borough, which are open 7 days a week, 8 to 8. And you don't have to be resident to attend any of those. So therefore, you can go and you could be an immediate, urgent, temporary patient at every GP practice. So we think there already is a lot of access in London.
Firstly, we had a good discussion and we all agreed that the idea being able to choose where we want to go for GP is the correct way to go. And we feel that is a right that everybody should have. But also at the same time that we should protect locals in that process, local residents, and that's going to be the challenge of the whole process. Secondly, we discussed about the IT system, and we thought that was quite important that all doctors should have a fully integrated IT system and that they should be able to access information from everywhere in the country, and we should be able to go and see a doctor if we're anywhere in the country, basically. So that IT system will give them the option of assessing us and looking after us in the way they should, in the quality of care that they should provide for us. We feel that there should be a levels of consistency in how the PCT manages the GPs, and it should be a unified process, like in terms of opening hours and standard training as well for staff, GPs and reception staff.
We had accountability as a sort of major issue, so what GP is responsible for what. A link to this was that people need to take more responsibility for themselves, and greater choice of GP practice sort of induces this idea. A link to that then is better patient education, so people need to be better educated about self-care when it is necessary to go to a doctor, perhaps in terms of having a cold. And also the importance of going to a GP sooner rather than later. The cost savings of this could actually be huge in the future. Another sort of like downside perhaps to all this is that more choice means greater capacity and greater spending of money. More people would probably be registered in GPs in cities, and this could force rural areas to rural practices to close.
The idea of having a card with a PIN number which you could then take to wherever you wanted to go was one of the ideas that was developed over here. Certainly dual registration we thought was reasonable, but I think it presupposes that the GP gets paid by their number of consultations they do rather than the number of people on their list. Or doctors to do more hours and actually receive patients possibly who aren't even registered. So in the walk-in centres, they ought to get paid for looking after people who live in the street population, maybe recent immigrants and so forth. There was a sort of secondary concern that there needs to be a balance on payments to GPs between the amount of work they do and perhaps their basic list. But there needs to be a swing towards payment by work rather than payment by list. That was certainly the general trend on this. The other point about having a card is that it ought to put the patient in charge of who looks at their records rather than the doctors. In London, the sort of things we're talking about, dual registration, being able to walk in with your card, are the sorts of things which in London will work. The other problem about home visits, we actually think that the home visiting services which some of our GPs are already running is a separate outfit to the GPs themselves turning out. And as we have in many parts of London, we have multi-borough after-hour services which do home visits. Those sorts of organisations like Camidoc could pick up the slack where there is dual registration and somebody's a long way away from their original home registered GP. And so those sort of home visiting services could take off to fill in the gaps.